folks hear me now? All right, very good. So we're going to get started. Sorry, everybody, including all the tech people, have a right to go to the bathroom too, so I very much appreciate it. So thanks all for coming back. We're going to transition to the managed care TAC portion of the presentation. I'm going to call it MCTAC, or I'm going to call it Managed Care TAC. When I say MCTAC, it frightens me because it starts to sound like McDonald's and Burger King and all of those kinds of things. We're trying to upscale and be more Panera Bread or Chipotle to try to really be a little more upscale about that. We've put one of the pieces of feedback that we've put on here over the course of time is just to get names and folks in. So we have a varying cast of characters that are doing these presentations over the course of I believe 12 or 13 of these that we're doing now. So Charlie Neighbors from CASA is usually doing this with us, but we have their CEO, Sam Ball, today doing it instead. But just to get names up there, just to introduce myself, which I didn't do this morning, I'm Andy Kleek. I'm a psychologist by training, and we have been doing this kind of technical assistance work for the last 3 years under the guise of the Children's Technical Assistance Center, which then grew into the Clinic Technical Assistance Center. So for those of you on the OMH side who run clinics, you probably recognize us from that. And then in addition, we've gone back a decade or so doing technical assistance on implementation of best practices. So it's really exciting to be here. I'm going to try to take and get everybody out of here by 2 today because I know everybody wants to get back on the road. But just very, very briefly to walk through what kind of technical assistance is going to be available. Some of that I'm going to have details on. Some of that there are going to be more details forthcoming. If you are on our mailing list if you are here today. So I strongly encourage you to start paying attention to the emails that come from mtac.info. There's going to be all sorts of those coming forward in the next couple weeks and months ahead. Please pay attention to those. As we develop and grow further, we will start to identify kind of subsets. So we'll be doing training for administrators, training for finance staff, training for frontline staff. And so we'll develop targeted email lists for those over time, but right now we just have everybody in a single system. So I'm going to talk a little bit about who we are, and then we're going to talk about kind of the critical readiness factors and how we've broken up the technical assistance that we're going to offer over the next really 2 years. And we're going to take a little time to talk about our training series, phase 2, which is some of the more strategic things that we're going to be doing with folks, as well as we're going to really cut down on the change management and the role of leadership. We'll probably be offering that as a standalone webinar or in-person training going forward, but there's just no way to cram as much information into here as possible. I imagine people's heads are full up to at least here. I'm hoping you've left like a little corner of your brain to listen to the TA that's available. And then at the end, we'll leave a couple minutes for questions, really focused on what are your needs around technical assistance. The more information we can get on that, the better. It helps us prioritize where we start as well. So what is MCTAC? So MCTAC, we're a training and consultation center really building on the work that we've done with the Clinic Technical Assistance Center over the last several years with a focus on working with all mental health and substance use agencies in New York State. And I want to emphasize all. So there are about plus 800, between 850 and 900 agencies, depending on which spreadsheet you use and which you put in and which you take out. Agencies in New York State providing substance use and mental health services. We have been contracted by OMH and OASIS to really work with all of them. And I want to emphasize that for a couple reasons. One, there's a conceptual decision there that goes into that. If you are going to work with some, you can go and do individualized technical assistance, right? So we can come out and meet with you in your offices and really provide individualized TA to folks on this transition. But because we're working with everyone, most of it is going to be group-based. Now, that doesn't mean there won't be some individualized attention within the context of that group, but most of it is going to be group-based. So we will be doing a lot of forums on this and a lot of different topics. We will be doing a lot of web-based training on a lot of different topics. We will be doing learning communities where we bring groups of providers to work together. For those of us who have done stuff like that in the past, many of you probably participated in learning communities. So we're going to be doing a lot of learning communities, but it's primarily going to be group-based and not individualized. Does that make sense to everybody? Okay. So I just want to emphasize that because I don't want to give the misconception that we're going to come out to your individual agency and meet with you individually. Okay. All right, so we're going to do a number of different things, and I think it's really important just to highlight some of the basic things. So a lot of what has been asked today in the Q&A as well as the presentations are, look, we just want foundational information. Where are the goalposts? What do I need to know in terms of the goalposts? That's where we're going to start. There are really two levels to this, and I think Bob, in either the baseball analogy or one of the other analogies, really highlighted this really well. There are things that are going to be foundational, but those foundational issues are not going to be sufficient, right? So there's this piece where you have to figure out how to get contracts with everybody. You have to figure out how to get the billing situation straightened out. You have to be ready to turn the lights on. In upstate, the lights turn on a little later than they do in the city, but you have to be ready to turn the lights on when the switch gets turned, right, to transition to managed care. That's all going to be necessary. If we don't do that and we don't help people make that transition, they're really going to struggle, and you're going to have all sorts of, really large systemic problems. But in order to be competitive and be one of the agencies that's going to be successful long term, there's much more strategic conversations that have to take place. So we're really rolling this out in kind of a two-stage approach. First, it's how do we make sure the lights stay on when the switch gets flipped. There we go. So we're going to focus on contracting, on billing, on those real kind of core issues. And then once we get everything live, after that, we will start focusing on those strategic conversations and really helping people through that. We are going to develop a lot of tools. So one of the questions that came up, I think several of them that came up today, focused on, well, how do I keep track between 10 different managed care plans? Who does what form do I use here? Who am I supposed to call for this? What do I do for that, right? One of the things that we're going to develop actually is a comprehensive online database which lists all the plans in New York State, where they're active in New York State, who the contact person is in each region, what's their email, what's their phone number, what specific form do they have, what are the kind of nuts and bolts things that you need to know by plan, because it's really hard to pull together. We're trying to pull it together, and we have the resources to do that, but for all of you to have to do that 877 individual times makes no sense. So we're going to do that. We'll post it online. We'll send it out electronically. We'll provide the opportunity for people to then people to then access it. Then we'll update it on, every couple months we'll update it and that kind of stuff. Is that something that will be helpful to people? Yes. Okay. So we're going to do some of that. We're going to develop a whole bunch of other tools which we're going to talk about over the course of the day, and we'll develop some assessment things. And the other piece I want to talk about a little bit is this transition to value-based purchasing. There's been some questions which start to gear towards outcomes, right? So there's the piece of what should government do around what kinds of outcomes will the managed care companies be held accountable for. But then as an organization, what kinds of things are you going to have to look at internally? And so we're going to be rolling out over the course of the next couple years a ever-increasing sophisticated version of outcomes management, and that'll be coming as well. And then I'm also going to talk about readiness as well, and managed care readiness. And some of you have filled out our readiness assessment. Some of you are hearing about it for the first time today, so we'll talk about that as well. One other piece I want to just raise today is that the managed care TAC is not an advocacy organization. So we do not do advocacy. That doesn't mean we won't be partnering with many of the advocacy organizations around the state, many of whom are here today. We will be partnering with them on a lot of different things as they work with their members. But we as an institution won't be doing advocacy. It doesn't make sense for us. We're funded by the state. But one of the things that we can do is provide information back to the state about what we're seeing in the field. So as we've moved forward on the clinic side, we've gotten lots of financial information from lots of mental health agencies. Now, I want to be really clear on this. I'll say this like 3 times over the course of the day. It'll be on tape and online and saved in memoriam. We will, as part of some of our projects, we will ask agencies to give us their individual agency information, because you can't do these learning communities, you can't do a readiness assessment unless agencies can give you their information. That information will stay with us. That information doesn't go back to the state, it doesn't go to the plans, it doesn't go to other providers, it stays with us. What we will do with that information, obviously within the context of a project, is work with providers with that information in the project. We will also feed that data back to the state, to you guys, to everybody in an aggregate format. But we will not share any agency's individual information, whether it be clinical or whether it be financial, with anybody. It stays with us. Does that make sense? Okay, I'll say it like 3 more times today because it's really important. We made that commitment at the beginning of the Clinic Technical Assistance Center. We've kept it for the last 3 years. And we also have that commitment from the state offices that they understand that we're going to get very different information if people know their information is going to the state than if they know it stays with us. So we've gotten that commitment on both sides, and so I just want to be really, really clear about that. But when we get that information, it does also allow us to feed back to you what we're starting to see in the field, and that's helpful. One of the questions we always get is, well, how do I compare to others, right? Well, if we have information on 200 providers around the state and we share that, you now know how you compare to other people. It also gives the state information on how the system is performing much quicker than they're going to get through claims data. One of the things that's happened on the clinic side is they're looking at CFR data, and we're getting data that's happening right now, and so that's been very helpful as they start to make those decisions as well. But that data is always going to go back de-identified and aggregated. Make sense? Okay. All right, so there's a bunch of people that make up the Managed Care Technical Assistance Center, and where there's a bunch of partners which we're going to talk about in a little more depth and have some representation from them as well in a minute. This slide is intentional. So a lot of times these TA centers are either totally academically driven or they're totally, provider driven, or they're one or the other, right? And I think we have been very, very mindful to not have a kind of single entity that's organizing this whole process. When it's totally academically driven, it ends up way up here and makes sense very well conceptually, and then the providers are like, yeah, but that makes absolutely no sense to me. And there's some of the people in our provider networks who've just told us that as we move forward, and it checks us internally. But if it's all provider driven, you don't have access to some of the resources that you get in academia. And so I just want to be clear that we really do cut across. So we are made up primarily, and the thing primarily runs out of the McSilver Institute where I work at NYU. We work closely on the kids side with ideas at the NYU School of Medicine, which is Kimberly Hoagwood shot. We have partnered for the last 3 years with CCSI, who is here in Forest today, and got everybody checked in. And they have, for you upstate, they've worked with counties and providers upstate for 20 years now and have really provided the business infrastructure and architecture behind what we do and have been hugely important as partners. Downstate, we're working with 2 provider organizations that will work with us upstate as well, both the Institute for Community Living and FEGS in the city. This will probably expand. We'll probably bring in some substance use providers to help as well. We also are working closely with NIAPRIS on the peer side, and we'll work closely with Families Together on the family advocate side of things. And then we're working with CASA, and they're going to talk in a second about what they're bringing to the table. But we're working with CASA to really give us some depth in the substance use side, because most of us are coming from the mental health side, and so CASA has come to really help us on the substance use side of things as well. Just very, very briefly for those of you who aren't familiar with us, so there's 500 mental health clinics in New York. I'm always surprised that it actually rounds up to 500. I've done the math a couple times because I'm always afraid somebody's going to say, well, do those numbers add up to 500? They actually do. So there's 500 mental health clinics in New York State. They go up and down, but it always seems to end up at 500. Over the last 3 years, we've worked with 70% of those clinics. We aspire to work with 100% of those clinics. We hope to get that same level of penetration on this project as well. We've been working with the kids clinics for 3 years now, moving into 4. We've worked with almost 80% of those clinics. We work with adult clinics for 2 years now, and we're up to almost 70% of those. So we really are deeply committed to working with all providers in New York State. That just says the same thing. So I'm going to invite Sam up to talk very briefly about CASA, and then we'll move forward.
Thanks, Andy. Not sure which one of us has more of a brand challenge problem, MCTAC or CASAColumbia. We get phone calls. People think we're a South American restaurant. So CASA stands for Center of Addiction and Substance Abuse. We're a nonprofit policy, education, research, and evaluation organization. It's affiliated with Columbia University and has been for 20 years, and in January we're going to be jointly affiliated with Yale University. The main tasks of CASA are primarily in translating addiction science into 2 interrelated areas. One is regulatory and healthcare policy recommendations, and the other is in the prevention and treatment practices for addiction. We're not a direct care provider, but providers along with policymakers and the general public are the groups to whom we provide information and tools and consult with around best practices and performance evaluation. We work very closely with federal and state funders, particularly in the state OASAS and DOH, and then federally with the National Institute on Drug Abuse and SAMHSA. And actually Charlie Neighbors, who's our project leader, is down in Washington at a Health Homes meeting, so he sent me up here with his 2 slides and told me I needed to come up with my own comments, so here they are. But with our state and federal funders, we're mostly focused around healthcare reform initiatives. And when the state began this initiative, we were sought out as partners with experience in Medicaid reform efforts, with a particular interest in trying to represent the needs of substance abuse treatment providers, particularly as the system integrates addiction-specific care services into the physical and mental health care arena. And looking for an agency that works well with McSilver and the Managed Care Technical Assistance Center.
You skipped ahead to like one more. There
Is it this one?
Yeah, that's the one. If you just click a couple times, it'll all come up.
Oh, we did this like this, okay. Get them all up there first. So CASA's senior leadership group has significant expertise in substance abuse treatment and particularly workforce development around provider and supervisory competencies. We are very involved in healthcare policy and law, as I mentioned, public health and prevention services, and in business development and partnerships. And then a final strength that we have is in the area of data analytics, both smaller scale treatment outcome studies and larger administrative databases. And our overarching skills are summarized sort of by the ABC areas, evidence-based practices for addiction prevention and treatment, use of process of improvement strategies, and database performance monitoring. And those are really sort of, I would say, our bread and butter with regard to this initiative. We have collaborated with various state agencies on those 3 bottom bullet points. These are active areas of collaboration with OASIS and New York State agencies around the development of the locator instrument, evaluating health homes and other Medicaid reform initiatives, and a big project that we're doing right now, which is implementing and evaluating screening, brief intervention, and referral to treatment in the North Shore LIJ system. And then prior to that, we've had significant program evaluation work on methadone maintenance, homeless services, and adolescent substance abuse treatment that's co-occurring with other psychiatric disorders. And those initiatives have been run by a group of 3 clinical psychologists, Charlie Neighbors, who I mentioned, John Morgenstern, and Aaron Hogue, and I'm kind of the new kid on the block coming to CASA. As in January, I became the CEO, and I came from Connecticut, where I, for about 6 years, directed a long-term residential therapeutic community, and have also done medication-assisted treatments and the other types of outpatient, what we used to call outpatient drug-free treatments. So I think we're bringing a range of talent to the task, and in addition to the talent, I think we also just bring sort of a sense of mission and priority around substance abuse, and sort of view it as our job, in addition to providing technical assistance, is to make sure that no one loses sight of the fact that substance use and addiction are the primary contributors to health care and criminal justice costs. And our organization will continue to be advocates for those individuals and families affected by the disease, and to make sure that addiction maintains its attention as we tackle these very difficult projects of trying to integrate addiction care into the broader initiatives to improve health and prevent and treat this disease. So good luck to everybody, including us.
All right. Okay, so next. All right. So one of the things that we're also going to try to do is serve as a clearinghouse for others. So Managed Care TAC is not going to be the only technical assistance being provided, not only by state-funded institutions, but also by, advocacy organizations, by trade associations, by many other people around the state. And so one of the roles that we see ourselves starting to grow into is really to start to serve as a clearinghouse for all those efforts, so you don't have to be in 7 places on Tuesday. Because one of the things that these things are going to start to back up, right? And we've noticed some of that. So we are also going to partner closely with the other organizations in the state that are doing TA. One of those is the Center for Practice Innovation, which has been working in New York State for almost the last 10 years now. We started out doing wellness self-management with them like 8 or 9 years ago. And so they're going to be working closely with us, and I just want to invite Nancy up here to say very briefly kind of what they're doing, and then we'll dive into the content stuff.
Oh, I'm sorry. Thank you. Before I start, who here has heard of the Center for Practice Innovations? Quite a few people. Has anyone taken any of the face-to-face or online training or participated in webinars? Great. So very briefly, we're largely supported by OMH but we also do partner with OASIS. Pat Lindcourt's actually been involved with us on a number of our co-occurring projects to help promote evidence-based practices throughout the state. We provide online and some face-to-face training for assertive community treatment. We also have a lot of implementation supports through webinars, learning collaboratives, and lots of tools that are already developed. What comes to mind immediately is our new employment resource book that maps very nicely onto those different categories of the 1915I services, the pre-vocational and all the way through the support. So as you can see, I'm not going to read that list. We have a number of trainings and supports around core practices that we hope will help you get to where you need in terms of what Bob Myers was talking about earlier in demonstrating outcomes, and hopefully complements nicely the other training around the state and what MCTAC is also providing. We've reached quite a few people, a number of you in the room, as you can see from those numbers, and we will be working closely with the managed care agencies as this rolls out to make sure that we're providing training that's focused on what you need to demonstrate your value. And in fact, we are already getting questions from some managed care about programs who've completed some training. So thank you. We look forward to working with MCTAC and you in the future.
Thanks. Okay. So I have a colleague who says that started saying a couple of years ago, you put any three letters together, you get a new payment system. Does that sound familiar to folks? Unfortunately, it's expanded beyond three letters now. We have MLTCs, we have DISRIP. If it gets more than DISRIP, that's kind of it for me. I think that's about as long as we can handle. And then since there's like $8 billion in it, I don't think anything's going to get bigger than DISRIP. But I just put this up here because one of the things, we need a little bit of a joke at this point. We've been going for 3.5 hours, so I admire everybody's patience in sitting through this. But the other thing, the reason I put this up here is because one of the things that we're going to start to do with folks after the lights get turned on and after the switch gets going is to start to help people think through what they need to do to integrate all these pieces together. So, Bob's up here talking about PPSs, and we've got, health homes and MRT, and you've got managed long-term care, and you got FIDA, you got all these different things. How do you start to knit all these things together so it makes some sense and so that you have a program that addresses these needs? How do you get involved in PPSs that are part of the DISRIP applications now? How do you start to knit these different pieces of things together? It's going to be critically important to being competitive going forward. So once we get through how do you turn the lights on in the city, it's April 1st, upstate it'll be later than that. How do you quickly shift to the start of the strategic conversations you need to start having, which is where your organization fits in all of these different pieces. And we're going to work really, really closely with folks to help them do that. I put this up here just to kind of give a very, very brief overview. I have this slide, which is frighteningly in its depth. I got the 20 slide version of this, which lays out every different program type. But there are between 850 and 900 agencies around New York State, and that's kind of our scope for this. So we're going to help people get the critical information they need before April 1st downstate and whenever we start upstate after that. The other thing is we're going to be providing content expertise, but we're also going to be really helping to get a sense from everybody of kind of what their level of preparedness is for this change. And we're going to develop tools, and I'm going to skip through this. Okay. So there's 4 basic things that we're doing. First of all, these kickoff events. We find these as critically important. They have sold out around the state. I think today we had 300 people in the room, another 400 plus online. We saw 800 people down in the city. We're going to do the Western New York ones as well. So, we view this as the first in a multi-step process to just get information out there. We will be providing as many opportunities as possible to repeat that information over and over again. The video from today will get chopped into first it'll go out as a big giant thing, right? But then it'll get chopped into multiple different segments. So if you need your staff to see something on, what Gary had to say, you can pull that up. If you need, something else, we'll do that as well. And then we're going to do kind of 2 global levels of training. Let me go back. 2 global levels of training. One is around informational stuff. We'll do a lot of training on informational things around contracting, around billing, and I'll talk about that in a little more depth. And for some of you, that'll be enough. You just like, look, I just need to know what Optum's form is, who I'm supposed to call, when I'm supposed to fill it out, when I need to get my services reauthorized, and I have a very sophisticated system, and I'll be fine after that. And that's great. But for some of you, other people need a little more than that. So we're going to do kind of what we're calling intensive training series. We have some horrible name for it right now, which will change. But basically what we'll do is we'll take that information, and for people who need more, we'll develop learning communities around those topics and pull you together with the kind of panel of experts in the area, but also pull you together with your peers and assign you to groups based on your level of readiness and the area that you need to focus on, and give you an opportunity to work together with some of your peers to really sort through those issues going forward. We want to make sure on every topic area that we cover everything in an informational way, but for those people who need additional services that we provide that as well. This is a whole range of the topics that we're going to cover, but let me go into some of them in a little more depth. And you can actually see them. Okay. So we're going to start talking about understanding managed care. Shifting from a volume-based to an outcome-based organization to a value-based organization. What does that mean if you've been fee-for-service for the last 30 years? What are the clinical implications for that? What are the business implications for that? We'll be pulling together panels of managed care leaders to really talk through what that means from their perspective. How do you transition from utilization review to utilization management? So when I worked in a clinic 10, 15 years ago, utilization review meant that me and the person next door to me in the office across the hall from me, once every 6 months, we took our charts, right? And we walked them across the hall, and I gave my charts to the woman who was across the hall, and she had this one-page face sheet, right? And she checked off all the little boxes, and then no one ever said to change anything. She just checked them off, and she gave mine back to her, and I did that, right? I guess we could do that electronically now with the HRs, but that was the process. So that's utilization review. But utilization management is a whole different thing, a much more complicated issue. And one of the things that has been the kind of subtext under what has been said by a lot of folks up here today is, yes, protections are going to be there for 2 years, but managed care plans are going to start watching in these 2 years. And you as an organization are going to have to pull together systems to start looking at what you do and how you do it and what the outcomes are now, because managed care plans are going to be watching what you do and how you do it. So putting utilization management procedures in place now rather than waiting for 2 years when all of a sudden people don't have to contract you anymore is going to be really important. And so we're going to provide a lot of TA on that. Understanding HARP, 1915I, and also the role of physicians. This is something that you can go home and do right now. So this is understanding your population is as much outcomes as everything, but we're going to start really simple. One of the questions that we're getting a lot is, which managed care plan should I talk to first? So there's, X number of, in the city there's going to be 10 plans working in New York City. Should I go talk to all of them? Who should I talk to first? One of the things that you can go back to and do right now is look at your clients that you are serving now and find out where your clients get their physical health managed care from, right? Anybody done that already? Okay, a couple folks are starting to do that. That's one of the things that you can start to do now, because the vast majority of those clients are going to stay with that plan when they transition to managed care. So there's a couple things you want to do. First, find out where they get their physical health managed care from. Find out if that plan is offering a HARP and if those clients are HARP eligible, right? If they're HARP eligible and the plan's offering a HARP, thank you. They're just going to stay there. Most likely they can move, but the likelihood is they'll stay there. If 90% of your clients are with one plan, go knock on that door right now. Go see them out front. Do all that stuff right now, right? Get a sense of that. If it turns out that 70% of your clients are HARP eligible and they're in a plan which isn't going to do a HARP, then you need to start having dialogue, one, internally, but also with those clients about what are their options going to be, because they're going to have to transition to plans or not have HARP services. So that's another thing that you can start to do. Get a sense of who your clients are going to be HARP eligible within the realm that we can do that and now. The other thing is to start to get a sense of your internal service patterns. When we start to go to like a fully outcome-driven system and all that, that's really scary. But what you can do with your billing, and I'll use kids for an example on this because I actually grew out of the kids world. So, we've been talking a lot about adults today, but I grew out of the kids world. So, if you're working with 7-year-olds with ADHD, what do you do with them? How many of them actually show up for that first appointment? When they come in for how many show up for the second appointment? Do you see them in individual therapy? Do you see them in group-based therapy? Do you see them for family therapy? How many of them see the doctor? Start to get a sense of what you do with your population now. We will be rolling out lots of tools to help you with that, but particularly on the issues of who your insurance plans are, you can get that out of your billing system already through eMedNey and some of those kinds of things. So start to do those kinds of things now, and we'll provide lots of TA on that as well. Okay, contracting. This is likely where we're going to start, because if you don't have contracts, you can't bill, you can't get paid. So I know that we've talked a little bit about that there might be standardized contracts across managed care plans, which we would be hugely supportive of. But we are going to do a lot of TA around contracting. For some of you who already have contracts with managed care plans, this might be something that you already feel comfortable with. That's fine. This is entirely voluntary. You sign up for what you sign up for. But for those of you who want to know more information, we'll provide that. What it looks like right now, and there should be some more information about this in the next couple of weeks, is we're going to do some in-person training on this, as well as some ongoing web-based training around who is, sorry, my brain's starting to leave me at this point in the afternoon. Some ongoing web-based training where we bring in an agency lawyer to talk from their perspective. We'll bring someone from government to talk from government perspective, and also provide some outside experts to people around contracting, because we recognize that not only is contracting coming for all of you upstate when you transition to managed care, but that FIDA thing is coming like on January. So we're going to start doing that right now. And then billing operations. This slide doesn't do this justice. It's got the least words on it, but it's like the scariest and biggest bucket here, right? So we're going to start focusing on billing in a big way, and there will be a kind of comprehensive plan to how we address that we're pulling together in the background right now, and I'm hoping will be out for folks in the next couple weeks. It's going to focus on everything from cash flow management in terms of how do you need to think about managed care when this switch gets flipped. I can't say that phrase for some reason. When this switch gets flipped, and what kind of contingency plans do you need to make, because things will be a little messy at the beginning, even in a perfect system. So how do you structure that? We're going to focus a lot on billing. Do you do billing now? If you don't do billing now, do you need to bring in a vendor? I liked the question. I liked that comment earlier, because we're trying to do the same thing, and it's not as easy as one would think it would be, right? It's very hard. So do you need to hire somebody? Are you going to build it on your own? Do you need to partner with 6 or 7 other agencies in your region to build a billing system together so you can share those costs? What do you need to know around each individual plan? So we're going to provide that as well. And then a whole comprehensive thing around utilization management that'll really go soup to nuts. So our initial offerings will be around contracting, around Managed Care 101, and around the issue of billing. So we're also going to build a bunch of tools. So one of the tools that I already mentioned is this idea of kind of building a comprehensive database that'll allow you to know what plans there are, who they serve, where they're active, who you should call, what their forms are. So that's one thing we're building. The other thing is that we have also heard from a lot of providers, look, I'm going to these forums, but my board's not coming to these forums, and I have to go back and talk to my board about what this is. My board has nothing to do with healthcare. They're members of the community. They have other jobs, and I need to explain managed care to them. So we're developing, it'll probably be a slide deck, which we'll roll out with some audio overview that you can use as well. But we're going to develop a slide deck that you can use with your board. We're going to develop a slide deck that you can use with your frontline staff, because they're sitting in a clinic right now actually seeing people. They're not here today, and we need to share this message with them too. How are their lives going to change? So we're going to provide a lot of training for those frontline staff. We also want to give you some tools that you can work with them as well. And then you have a bunch of consumers who receive services in your program, and this is going to have a big impact on their lives as well. So it's not on here, but we're also going to develop an equivalent level of services that you can use in your agency to start to educate consumers. Do those things sound like they'd be helpful to folks? Good. That's the end. No one said no so far, so I think we're going to keep going with those things. And then we're going to condense all of that into, anybody heard of wellness self-management? So that's where I started. So there was a guy named Tony Salerno sitting in the back of the room at the beginning who kind of taught me everything I know. And he had this idea that his kids were going to college, and we were trying to develop a user manual for wellness, and he was dropping off his kids at college, and he went and spent $700 in the bookstore to buy her all her books, right? And so they had like American history in one page on a laminate. And so he said, well, if we can get American history on one page, then we can get wellness on one page. And we use that for everything. So we'll condense as much of this information from today as possible into like a one-page front and back. because that's something you can stick on your wall. It's something you can give to your staff. It's something that just makes this make sense and highlights the key things, because even though it's been 3.5 hours of stuff, there are some really key features that you want to really remember. Okay, so those are some of the tools. The foundational training that I've talked about. So after each of those kind of foundational training sessions, what always happens to me when I go to a good training or a bad training is I take it back with me to my office, right? And I meet with people in my office, and maybe I'm all excited, and I come and we have a meeting. I say, I went to this great training, I learned all this stuff, and now what happens? I got like 17 questions, right? But the expert who did the training is now gone. So where do I ask my questions? So remember back to college. It's nice that Bob has used that analogy today. Remember back to college, you had office hours. Professor was there once a week for an hour. You go ask all your questions. So with CTAC, we've used office hours. We started it because our frontline staff for CTAC were getting overwhelmed with X million of emails. But now we use office hours because it's a place where you can come a week later, listen to the same expert or someone with the same skill set, and ask all those follow-up questions that you didn't remember to ask on the original content training. We found that to be incredibly helpful. It's all voluntary, but we'll follow up each of those sessions with something. So when we do contracting, we'll do a half day like this, and then like 2 weeks later, we'll have the guy who did the half day come and do like an hour and a half where he answers questions, because you're going to have lots of them. Okay? And then we're going to take those really critical topics. We won't do this on everything, but the really critical topics, I can't imagine billing won't be one of these. We'll develop learning collaboratives which go through those, and we'll assign you to groups of other agencies who are struggling with the same thing at about the same level of readiness. And so that leads me into, I skipped through this. Okay. So that leads me into the readiness assessment. So those of you who got our original emails, a couple weeks ago you got something called the Managed Care Readiness Assessment online. And one of the questions that we got from OMH and got from providers is, it was the same question. It was, how do we gauge where I as a provider am in terms of readiness for the transition to managed care? And how do we as a system gauge where the system is in the transition to managed care? And so working with our colleagues at CCSI who piloted something like this in Western New York, we've developed a readiness assessment. Now, I am the guy in the office when we do surveys who's always like, it can't take more than 5 minutes. It can only take 5 minutes. You can't, overwhelm people with stuff. They'll never fill it out. This is our one exception to that rule. There's no conceivable way to gauge somebody's managed care readiness in 10 minutes. And so what we have developed, and it's in your folder on the side that doesn't have your slides, it's a managed care readiness assessment tool. And in the folder, what it does is it covers all of these different content areas. Understanding managed care priorities, contracting, communications and reporting, IT system requirements, credentialing, level of care criteria. It goes through an entire list of all of the different critical areas that you need to prepare for managed care. You've gotten this online. You also have the hard copy in your folder. Normally what happens when I get a survey online is I give it to somebody in my office and they say, fill out this, can you fill out the survey and send it back? Because we're, research, so we want to make sure that we at least fill out other people's surveys. So we do that. Please don't do that this time. Do not send it to the person who fills out surveys for you. This is not designed for whoever sits in that office and goes online and types in the stuff. Don't do that. Get together with your core management team. To Gary's point, I think at the beginning, get together with your finance people, get together with your program people, get together with your executive management, and if you've got the IT person with you too, I know they speak a different language from many of us. We all went to social worker psychology school. We did that because we weren't good in math, most of us. Some of us may have for deep passion. I know Charlie went to because he was good at math and he's at CASA, but he's a research scientist. The rest of us went into it because we didn't know what that X with the E program. We're going to have to open that program now. Get together with all those key components of your staff and fill this out together. It is designed to give us information about where the field is in terms of managed care readiness. It is designed to give the state global feedback. I'm not going to send anybody's information specifically to the state, but we will give global feedback to the state to see where people are. And then we will do an online probably thing on where the state is to give you a sense of where you are compared to other people. We strongly encourage you folks to fill this out. It's due next Friday. We will, of course, probably extend the deadline a little bit. There'll be some like Jewish grandmotherly like pestering stuff. Please get them in. We've got a bunch of them in already. We'll continue to encourage folks to get those in. But when you get back, pull that group of people in your agency together and fill this out. It will be helpful to you, and it has been vetted. Not like vetted like it grew like to 3 times its original size vetted, but it's been vetted by the Plan Association, it's been vetted by providers, it's been vetted by DOH, OMH, and OASAS. It's been vetted by I'm using every acronym there is known to man. Oh, that's another tool we're going to develop. We're pulling together a glossary of all the different acronyms that are out there, because I can't keep them straight, so somebody's going to do that. It'll be online, so that way if you're an OMH provider, you'll know what the OASAS acronyms are, and if you're an OASAS provider, you'll know what the OMH acronyms are. But just be very mindful of the fact that we're pulling this together, and please send it back in. So you'll get lots of pestering emails from folks. It's due next Friday, October 10th. We want to give folks at least a week after this form to fill it out, but we will accept them going forward, and it will be the basis for a lot of our other trainings in terms of priorities where we start, but also in terms of how people get assigned to groups and stuff like that. Make sense to folks? Okay. All right. Let me go back one. Okay. So once you fill it out on a piece of paper like this. You can print it out when you get the email, when you go online, you can print out the PDF version of this, and then we have a Qualtrics link, which is like SurveyMonkey, but the thing that we use. So then once you fill it out as a group, give it to your survey person, and then they can enter it online. So that's kind of the process going forward with that. We will provide all sorts of feedback about it. If you have questions, please email us at mtacinfo.nyu.edu, and it's on these slides as well. Please send that back. We're hoping to get several hundred of these so we really get a comprehensive picture of where the provider community is, both from an OASAS perspective, from an OMH perspective, upstate versus downstate, counties versus, community-based providers, to really look at the entire system. Okay. Timeline is we're starting now. We're going to keep going. We're going to focus on this deadline of April 1st for the city, but that doesn't mean that if you're an upstate provider or you're a kids provider, you shouldn't start signing up for stuff now. It's not like in a perfect system we wouldn't have started this 2 years ago. So start signing up for this now. We do not anticipate having to say no to people for things, so if you want to start signing up for stuff, please come. We're going to roll as much of this out statewide all at once as possible, and there's going to be a tremendous amount of information going forward. Looking forward to 2015, 2016, once we get through the billing structures, once we get through those kind of nuts and bolts issues, we are really going to transition to these kind of strategic level discussions about how do you as an agency strategically position yourselves to be successful going forward. It is going to be, I know Bob said it, I think Gary said it too, is going to be necessary but not sufficient that you figure out how to get a bill in. You're really going to have to think strategically, and that's a big part of our job going forward. And in all honesty, it's a funner part of this rather than just like what form do you fill out to get the bills in. So I want to kind of wrap up with this. So we were talking in the office about what it's like in the world right now. And I have less gray hair than some of my colleagues, although more gray hair than when we started this process. You can't see it from back there, but it's growing every day. I go to the barber and there's more hair. And one of my colleagues said it's like being in a raft. That we're whitewater rafting. And there's a couple things I just want to highlight with that. First of all, I had to find a picture when no one was falling out of the raft. That was really important. And just also how MCTAC, see we do CTAC, we do MCTAC, it goes back and forth. But how we view ourselves. We are not a life jacket. Agencies are going to have to make decisions strategically about what they're going to do, and those are going to be your decisions. They're not going to be our decisions ultimately. So we're not a life jacket, but we really do view ourselves as a paddle. We're a tool. You can participate if you want. We're entirely voluntary. You can sign up for as much as you want. You can do every single thing. You can sign up for some things. You can use us how you want. Hopefully you won't throw us in the water. We would prefer you not hit your colleagues in the head with us. But you can also row with us. So we really want to identify ourselves as a paddle. But one of the things that started happening over the summer, my boss uses this Buddha analogy when people get stressed, or when her family's like, she's got teenagers, so she brings a Buddha home and sits it on the table and says, all right, everybody calm down. So over the summer, as we were trying to plan all these events, she started sending me texts of Buddhas, which were a little frightening to me, because some of them were kind of scary looking. But what it highlighted for me is that even though it feels like this, we have to remain calm and we have to be level-headed as we go forward. So as we go forward in this process, I am starting to visualize the world in the next couple of years is we may be in the raft, but basically we need to be Buddhas in the raft and to be calm and Zen-like as we move forward in this process in order to really be successful. So, it's really easy to make very rash decisions to just be like, we've had agencies, all right, we're clinics, so we're going to fire all our staff and bring them back the next day as fee-for-service staff and without looking at data or anything. But there's going to be like a thoughtful, planful process that's going to have to take place in order for people to be successful. So another thing that I just want to highlight for folks, we have a whole change management section which we've had to cut out because the time just runs out very quickly in these events. But I want to highlight this piece, that if you've done everything we've talked about, right, you've pulled together that team, you're meeting on a weekly basis, you're really trying to work on all these issues, to really structure all these issues, it may seem very, very strategic to you in those meetings about your planful process for rolling this out. Your staff may view that as shock change, right? Your staff are not in those meetings. Your staff are in clinics or residential programs or wherever they happen to be working with clients, which is where they should be. But to be mindful of the fact that this may be viewed as a shock to them and to be very helpful in transitioning them slowly to this process. So I just highlight that. We're going to do a lot more on change management and workflow development going forward because it's going to be critically important to do that. But just some kind of, I've hit most of this, but just some kind of closing thoughts before we jump to questions. Identify that team. Get your executive leadership, your finance folks, your program leadership together, your evaluation staff if you have them to work closely on this. This is not a one-person job. Identify somebody who's responsible in your agency for the transition, who has access to your CEO and your executive leadership because they got to have some power in the organization. They're not going to be able to get it done. Please fill out the readiness assessment. It'll be helpful to you to give you a sense of where you are. It'll be helpful to us to figure out what we do first. It'll help the state to give the state a sense of where the community is. And then obviously, I don't think anybody doesn't know that there's going to be a tremendous amount of time and effort into this. So with that, I'm going to move forward. We'd like to hear from all of you. If folks have questions, I know Gary's still here to answer any more government questions. But also, if there's areas that you have specific questions on or specific areas of priorities for you in terms of TA, I'd be glad to hear that too. So with that, if you have questions, please jump up to the mic, and we have about 5 minutes to take questions before we wrap up. So we have so thoroughly answered everyone's questions about the transition to managed care that we're going to move forward. Overwhelmed us, right. Okay, so yes. Oh, one more thing before people run out the door. There's a feedback survey on the same side as your readiness assessment, and we do have one question. So we're going to take one question. Please kind of wait for the person to ask the question, then we'll go forward. Yeah.
It's one question. Perhaps you're going to want to redirect it. I'm Margaret Coker. I'm from Schenectady County Office of Community Services, and we are not a county provider. We are, essentially doing oversight of the behavioral health systems, and I'm wondering what role or what kind of training is going to be provided to the local government units in assisting all of the providers.
So we're actually going to be providing some training through MCTAC to the local, and I know we have a meeting with the county and local mental hygiene directors in the near future to actually start those discussions about how to do that. So we would want to partner with all of you as you do that. CCSI has been working with counties for 20 years, so that is very important, and especially upstate where the providers, and we're working closely with the city, county as well. So yeah, we're going to be focusing on that as well.
Good.
Before we wrap up, I just want to highlight that there also is a feedback survey in your folder. Please fill it out. The feedback is very important. We take it very seriously. We've made changes to this presentation in the 9 times we've done it now based on that feedback. So please hand it to one of the folks at the registration desk on your way out. I want to take a minute to just thank everybody for coming today. If you need an extra stress ball after today, please grab one, and have a safe trip home. Thanks so much, everybody.